So if you look at your start, and this may be a little confusing, we actually look at three things. RPMs, respirations, perfusion, and mental status. A mass casualty incident is when we would institute this, and a mass casualty incident could be as few as 5 patients and as many as thousands. They used this system in New York when they had the Trade Center. They used it in Oklahoma when they had the Oklahoma bombing. So this is a system that's used pretty frequently pre-hospital. Once you get into the hospital, they have other systems. But what this system is set up to do is do the most good for the most number of patients. Okay? So unfortunately, sometimes you have to come up to a patient and say, I can't do anything for him. I need to move on. Okay? And that's one of the hardest things about this system. But what we need to remember, when we have hundreds of patients, if we spend too much time with patient number 2, is patient number 99 going to die because we spent too much time with him? Okay. So we start out, when we get on scene, first thing we're going to do is say, everybody who can walk over to that tree and sit down. If they can walk over to that tree, they are considered a green. That means they're not really hurt that badly. We don't need to worry about them right away. When we get people on scene, more people than just 2 or 3, we're going to send somebody over there to secondarily triage those people. So if they are having a problem, we will pick it up. Then we will walk up to our first patient. We'll say, this lady's our first patient. I'm going to say, is she breathing? Is she breathing too fast? The rate on here tells you if she's over 30, she's a red. I'm done with her, I can move on. If she's under 30, then I need to look at her perfusion. Now you can do that one of 2 ways. You can look at it by feeling for a radial pulse, or you can do it by capillary refill. Basically, if you grab your finger and you squeeze it, it turns all red. How long does it take for it to go back to normal? Normal is 2 seconds. So if it's greater than 2 seconds, that's considered abnormal. We would make them a red. If they don't have a radial pulse, they would be a red. You don't check both, you check one or the other. Radial pulses are usually better to check, but if you're not familiar with doing them, capillary refill may be the better way to go. The other issue with capillary refill is we need to remember that somebody's really old, their refill is not going to be normal. So it may be radial pulse is a better way to go. So we did respirations. We do perfusion. If their perfusion's good, they have a radial pulse or their cap refill is less than 2 seconds, then we're going to move on to mental status. AVPU is AVPU. Okay, alert, which means they're looking around at you. Verbal, that means they can talk to you. P is painful, they respond only to painful stimulus, and U is unresponsive. So typically when we're talking about mental status, if they can talk to me at all, they're an A or a V. If they're not talking to me, or if they only talk to me when I elicit pain on them, then they're a P or a U. So if they're a P or a U, they're going to be red. If they're an A or a V, they're going to be yellow. If the patient is not breathing when you get to him or her, what you will do is do a head tilt, chin lift. And if they start breathing, then they would be a red. Now normally in a trauma, we do a jaw thrust, but in an MCI situation, we can't do that because we don't have the hands to do it. We use 2 different types of things to actually identify the patients when we do this. We use either triage tape, which has green, yellow, red, or black tape, or we use triage tags. Either way, the patient's going to wind up with a triage tag. But when you have multiple patients, this tape works much better and quicker than these tags do. Okay? There's a lot of room to write things on these tags. In triage, we don't write on them. We write on them in the treatment section or when we do secondary triage, which would be the treatment section or the ambulance. What you would do is actually say they're a yellow, I would rip off the green and one yellow. So that's what stays on the patient. Is it better to under triage or over triage? It's really not better to do one thing or another. If you're not sure and they're on the borderline, then it's better to over triage. But what we need to remember is the more reds we have, that's the more people that we have to transport first to the hospital. So some of those yellows may develop into reds anyway. Say I labeled this lady yellow. She gets over the treatment and they re-triage her, and now they triage her as a red, then they would just rip that off. These, basically, you take a piece of the tape and we put it around their wrist. You can put it around their arm, tie it around their arm. You want to do it somewhere where it's obvious that people can see it. The other issue with using this over that is here we ripped off the tag, so I can throw this in my pocket and I can remember to pull these out and then count how many yellows, how many greens I have. With this, I have to take a little piece and maybe put it in my pocket. You need to keep track of how many patients you have, how many greens, reds, yellows, and blacks. Blacks are not as important to the overall, but we need to know the incident commander. There's one person that's going to be in charge, and you have to go to him and say, I have this many yellow, this many red, so they know what hospitals to send people to. So if we have 50 patients, we're not going to send 50 patients to Ocala. We're not going to send 50 patients to Shands. We have to divvy them up between all the hospitals. Sometimes we have to send them down to the villages or out to Citrus or wherever. First unit on the scene, one of them has to be incident commander. That doesn't always happen that way, but one of them is supposed to be incident commander. So he's supposed to or she's supposed to direct all the people coming in and what they should be doing until somebody takes it over from them. The other person should be doing triage. So sometimes it's only one person initially doing triage, which is the tag system or the tape system works very quickly. Now, if you had a mass casualty incident where you had multiple patients and you already triaged the patients, typically we have treatment areas that are set up in green, yellow, red. You may have a morgue area, but typically, unless you have to move a body, we don't move bodies because it may be a crime scene. So unless you have to, we don't necessarily move them. So you may be assigned, say, to the red area, and in that area you have to do vital signs. You have to get the information that you need to fill here. When you have the yellow area and they're able to do some stuff, you may have some pencils available and let them write their name and address and the patient information on the back. That would save you some time in doing that. What these cards do, and this is why everybody gets one, you can see there's barcodes on them, but there's also little pieces that we can rip off. At the very top of these cards, you have personal property. So if you take personal property off the patient, you can put it in a bag, put this sticker in it, and then it can match up with these numbers here on this patient. The one below it says destination via. Basically, the transport officer is going to say, you're going to Monroe by ambulance number 66. And that way he keeps that so we can have a better coordination as to where patients went. Unfortunately, as you all know, and on the back it says patient name, on any mass casualty incident, it's very hard to match up where the patients are. Do we do any treatment? The only treatment that you would do in the triage situation, in the start triage, is any major bleeding. What's major bleeding? It's something that they're going to die if you don't stop that bleeding. So if you have a pumper, you have an arterial bleed that's pumping out, that would be controlled. You would wrap it up and then move on to your next patient. Now, the biggest problem with triage, and this is the thing you'll have the hardest time with, and that's what our guys in the field have the hardest time with. You go up and the guy's legs are maybe twisted, they have a broken arm, they have something hanging out of their chest. Immediately, you're like taken back by that injury, and you say, they're red. They might not be. You need to go through your RPMs. Just because all their teeth are missing doesn't mean that they're ready. All right, I'm going to quick run over the jump start. The main difference in the jump start is that the respiratory rate, we have an upper and a lower limit. The upper limit is 45, the lower limit is 15. But the one thing we do with pediatric patients that we don't do with adults is we actually will give them rescue breaths if they're not breathing. So if I have a pediatric who is not breathing, I will open his airway. If he's still not breathing, I will check for a pulse. If he has a pulse and he's not breathing, I will give him 5 rescue breaths. And the reason being is that pediatric patients typically go into cardiac arrest as a result of respiratory issues. So there's a good chance that we can start their breathing. Right? If they don't start breathing then, even though they may have a pulse, we're going to say they're in the morgue. We don't do full CPR. Again, we're trying to do the best for the most number of people. One more thing, if somebody has a sucking chest wound, is that a life threat? No. You have a hole in your chest and it's sucking air in from outside. It's a red. Well, what we probably need to do is cover up that hole so it stops sucking more air in. Okay, so that would be something we would do. So major bleeding or a sucking chest wound, you're going to treat initially. And you're not going to take 10 years to do that. You're just going to boom, tape it, move on. They're red. Most MCIs are trauma related. Most patients who go into cardiac arrest as a result of a trauma have very low success rates of resuscitation. If I go into cardiac arrest because I bled out, there's nothing you're going to do. You could do CPR all day and you're still not going to resuscitate. So if we do CPR, I have 2 people working on CPR. I may only have one other person to triage all the rest of the patients, depending on the number. Now, if you have a lot of people there and you're able to do that, then by all means you could do that. Because we're trying to do the best for the most number of people.